Dr. Hiral, we can begin the
Yeah,
session now.
sure.
Yeah.
Perfect. Thank
Over
you
to
so
you, sir.
much, Dr. Sunil. Thank you. So I'm just going to share my screen. Sunil, Akash, Vishika, please let me know if you can see my screen or not. Bear with me 1 second. Oh, can you see my screen?
Yes.
Yes, sir.
Yep.
Yes,
Fantastic.
yes.
So a warm welcome to all sort of audience members and participants today, and a warm welcome to our distinguished speakers, and a very big thank you to the National Health Authority for giving us the opportunity to showcase some of the work that we're doing on adaptive HTA and how it can help inform decision making on health benefits packages and other things like standard treatment guidelines and procurement. You've already had, I think, 3 to 4 webinars on, or 3 webinars at least on HTA prior to this. So that's coming from a very, very obviously methodological and sort of gold standard view. And so today we talk about adaptive HTA, which is almost a repackaging of HTA and a new way to think about this on how to inform decision making. As Dr. Sunil mentioned, that we have a very distinguished lineup of speakers and panelists today. And for those of you that joined late, we have Cassie or Miss Cassandra Nemzov from the International Decision Support Initiative at the Center for Global Development. Prior to CGD, Cassie was working for the Clinton Health Access Initiative and PwC, working on various aspects of health financing. And lately, she's taken up a PhD on adaptive HTA at the London School of Hygiene and Tropical Medicine and continues to lead the development of adaptive HTA methods and processes globally. We also have Dr. Manju Sengar, who is a professor in medical oncology at the Tata Memorial Hospital in Mumbai. Manju completed her training in medical oncology from AIMS, New Delhi. She also has diplomas from LSHTM and is an Accord alumnus from Duke University, Durham. Her research areas include non-Hodgkin's lymphomas in HIV and AIDS and adult acute lymphoblastic leukemia. She's also the principal investigator for many studies as well on multicentric clinical trials. We also have Dr. Pramesh, who's the director of the Tata Memorial Hospital and a thoracic surgeon. He's also a member of the Clinical Research Secretariat and the convener of the National Cancer Grid, which is a very large network of 177 cancer centers across the whole of India. Dr. Paresh works extensively on eliminating disparities in cancer care by enabling uniform standards of cancer care, promoting equity and rational use of healthcare resources, and also promoting collaborative and multicentric research. He as well is also an investigator on several multicentric trials and has a strong interest in biostatistics, clinical trials, and collaborative research. We also have Dr. Shankar Prinja, who many of you know from the past 3 webinars. And Dr. Shankar Prinja is an additional professor of health economics in the School of Public Health in PGI MER Chandigarh. He is a medical doctor with specialization in community medicine. His main field of work is in health economics, and he's completed his PhD and MSc at the London School of Hygiene and Tropical Medicine and the London School of Economics, respectively. His main research interests involve economic evaluation of healthcare interventions and programs, costing of healthcare services, and analyzing impact of health. And finally, we have Dr. Ganesan Karthikeyan, who is a professor of cardiology at the Cardiothoracic Sciences Center in AIMS, New Delhi. He received his doctorate of medicine in cardiology from AIMS as well, and he also holds a master in health research methodology from McMaster University. He's an international fellow of the Population Health Research Institute at McMaster, and his research is mainly focused on cardiovascular disease affecting low and middle income countries, and is also a board member of Health Technology Assessment India. So a very warm welcome to our panelists and our speakers today, and thank you very much for taking the time out to showcase some of the methods that you've been working on and for sort of participating in this training session. And finally, I go through the agenda today. So as I mentioned, I've done the welcome and overview, and we'll dive straight into an introduction on what adaptive HTA is by Cassie Nemzov. She'll be going through what adaptive HTA is, what IDSI has done before, and really what the potential strengths and limitations are of this. We'll then have a presentation by Dr. Manju Sengar, who will go through the NCG cancer guidelines and health benefits packages, and the need for using adaptive HTA methods and what the National Cancer Grid has done until now. And finally, we'll end with a panel discussion focusing on the role of adaptive HTA to inform benefits packages, treatment guidelines, procurement, and all sorts of things. And that's with our panelists today. And of course, please do share your questions in the chat box. I'll have them ready for the Q&A at the end for our panelists. You know, we welcome all sorts of questions, and we're always happy to try and answer them as much as possible, or within whatever we can answer as well, of course. And so without ado, I'd like to introduce Cassie. Cassie, if you can begin the presentation, then that would be great.
Yes, thanks very much, Hiral. Can I check that I'm audible?
Yes, I can hear you.
Great. And I will just share my screen. Sorry, give me 1 second. It looks like it's in presenter mode.
Cassie, would you like me to share my presentation? Or?
Actually, if you could, that would be great.
Yeah, okay.
Thank
No
you.
problem.
Sorry about that.
It's okay. So I'm going to let me know when to change slides.
Will do.
There we go. Yeah.
Great. Thank you so much. Good afternoon, everyone. Thanks, Hiral, for the great introduction. As Hiral mentioned, I work with him together at the International Decision Support Initiative of Global Developments in London, and I've recently started my PhD on the topic of adaptive HTA at the London School of Hygiene and Tropical Medicine. So my job today is just to give you a very brief introduction to what adaptive HTA is. And so take a step back, Hiral has mentioned that you've already had a few different webinars on the more traditional approaches to HTA. So just as a refresher, HTA is really a process to evaluate properties and effects of different health technologies to inform policymaking. And so what I want to emphasize with this slide is that HTA is not just about the analysis at the second step of this process, but it's a 5-step process that starts with topic selection and scoping, then moves on to analysis, then moves on to appraisal or looking at the evidence and evaluating its quality, making decisions, and moving on to implementation. Next slide, please. HTA can be used to inform a wide range of different health decisions. This includes information on priority setting, but also on purchasing and quality improvement. So the focus of today's session is really about health benefits packages. But this is just to highlight that HTA in its different forms can inform essential medicines lists, it can inform strategic purchasing, clinical guidelines, and they're all really linked together. So it's not like HTA just informs one thing, but it has knock-on effects where it can affect multiple policy decisions and be very effective in that way. Next slide, please. So moving on to adaptive HTA, to give you a bit of background on why we started to think about HTA and repackaging it in a different way. The issue is really that no two countries have the same approach to health technology assessment. Traditional HTA, like the one that you've learned about in the last few webinars, can be demanding of time, data, resources, and expertise. It can also be different in different countries because different policymakers have expectations about when they need information and what type of information they need in order to make decisions. Even NICE, the UK HTA body, created a more rapid approach to HTA just 5 years after it started in the form of a single technology appraisal. So we think of adaptive HTA as an additional tool in the HTA toolbox, which leverages or adapts available evidence from international contexts on the potential safety, effectiveness, or cost effectiveness of technology to inform policy. Approaches to AHTA can vary and they're not standardized, but they are fit for purpose and are focused on context specificity. Many countries already have AHTAs in their toolbox under various names. For example, Rapid HTA or Mini HTA. It comes in different names and it's come in different forms, but the same thinking exists where we adapt one or multiple of the 5 steps that I showed you in the first slide. So like I mentioned, AHTA can include all 5 steps in the HTA process, though how it's executed in different countries could adapt one or multiple of them. Methodologically, it might adapt available international methods, data, or models from the literature or other HTA agencies to expedite evidence generation. And from a process perspective, it can be adapted. HTA can be adapted for AHTA, things like topic selection and appraisal, but it should still be underscored by key HTA principles such as transparency, independence, consultation, and accessibility. Next slide, please. So this is a rather busy looking slide, but it comes from a commentary which we recently published, and it's just to illustrate how traditional and adaptive HTA might differ. So on the left-hand side, you see rows for the 5 different steps that I mentioned before, and then a description of how they might differ between traditional and adaptive HTA and the trade-offs on the slide. And so adaptive HTA might take a bit less time. The topic selection might use fewer criteria or be pragmatic in nature. Analysis will probably not be a de novo economic evaluation, but would be different types of options, and I'll get onto that later. Data sourcing may be less systematic. Appraisal could be a modified appraisal process. And implementation, like I mentioned on the second slide, can be wide-ranging depending on option. The important point here is that there's trade-offs between traditional and adaptive HTA. Timeliness, level of comprehension, local relevance, they may differ between traditional and adaptive HTA. And that's why we say adaptive HTA is a tool in the toolbox that should be appropriate for certain research questions, but it may not be appropriate for all research questions. Next slide. So just to give you an idea of a couple of ways that adaptive HTA has been executed in practice from our perspective, these few examples are focused more on the analytical component and less on the other 5 steps, but that's not to say that that's the only way. So this is the Canadian Rapid Response Service. It's a response service through the Canadian HTA agency, which provides information to the MLH, regional health authorities, and healthcare institutions. And it provides different levels of products depending on the question. So it can produce you a reference list in 5 to 10 days, all the way up to a systematic review. But what they're doing is doing a limited search of the published literature in order to provide evidence of safety, clinical effectiveness, and cost effectiveness. And the topics are limited to the list you see there, so things like drugs, devices, and diagnostic tests. On this slide, you can see 2 different examples. This actually is more linked to benefit package and cost drivers. So we've been involved in projects in both Vietnam and Romania. In Vietnam, we looked at utilization of the top 13 most expensive drugs and compared it to clinical utilization data, and actually found that of the top 13 most expensive drugs by expenditure, 51% of all of that expenditure was actually being used on inappropriate indications. We identified some significant cost savings, 147 million in annual savings could be achieved just by removing those inappropriate indications. In Romania, we took a similar but 2-pronged approach where we looked at the top 50 medicines by expenditure and compared them with international benchmarks on things like medicines listed for indications outside of their terms of marketing, or medicines listed for indications in settings where they may not be cost effective. This was paired with a de facto approach to HTA, where we compared UK prices to Romanian prices, adjusting by an appropriate ratio. And we found that 30 of the 50 top medicines on the formulary were likely to be not cost effective. And the de facto bit, that second bit, I think we'll get onto that more later with the India specific examples. But these are just examples to say we can be pragmatic about what types of topics that we look at in terms of HTA and what information we're finding in order to find efficiencies within the system. Next slide, please. On this slide, we have just a few strengths and limitations of AHTA. Strengths allows policymakers to make quick evidence-based decisions. It can reduce the domestic analytical burdens for the right topics. It can offer evidence where there may otherwise be none, where a decision may be made anyway. It can also quickly build capacity for wide-ranging stakeholders and identify low-hanging fruits, very cost-effective or cost-ineffective technologies where we don't need to do a full analysis and we can save the analytical capacity for other topics. And it can create impetus for future HTA work. On the other hand, it does have limitations. It's limited to topics which are well studied in other countries. And those countries' health systems are likely have different characteristics, so the transferability of international data should be considered. It demands appraisal expertise, so not only the analytical bit, but also to appraise how we look at the evidence, how we make decisions based on it. It could risk leading to suboptimal decisions if that transferability of international data is not taken into account enough. It may only build part of wide-ranging capacity that's needed for conduct of HTA. And if we were to do too many quick ones at the same time, it could put a strain on the health system's finances if we were looking at really expensive drugs. Next slide. And just to wrap up, just to say decisions will always be taken with varying levels of evidence. And I think this is why I've been talking about adaptive HTA for a while. Not all AHTAs need a traditional approach. AHTA is simply one tool in the toolbox. AHTA can aid in providing cost-effectiveness evidence where previously it wasn't used. And can also identify interventions that are marginally cost-effective or where further research is needed. So it could just be a first step where we identify what types of interventions we want to look at, and we decide actually we need more evidence and we need to do something more detailed in the future. The future work we have planned on this topic is a global systematic review on adaptive approaches. Like I've mentioned, we know HTA agencies are doing them in various forms, so from both HTA agencies and the published literature, as well as the development of an HTA manual for low and middle income countries. With that, I'll conclude there. Hopefully I'm within the time, and I'll hand back to you, Hiral. Thanks so much.
Thank you so much, Cassie, for that very transparent and clear presentation. I'm sure some of the examples that you showed with regards to Romania and Vietnam will resonate with all of our participants here today, who are obviously focusing on updating and generating new benefits packages or updating tariffs as well. I'd like to bring in Dr. Manju now, who has been championing a lot of the work with the NCG and CGD together on adaptive HTA in India. So Dr. Manju, I think are you on this chat? I think you are.
I'm there. I'm there.
Fantastic.
Yeah, I'm just going to try and share my screen.
No problem.
Is my screen visible or?
Yeah, it's on
Yes, ma'am.
the normal mode. You'll need to change it to presentation mode.
I'll let Yeah. Is it better now? Is it?
Yes.
Yeah. Okay. Thank you. Thank you, Hiral, for that kind introduction, and the NHA team and the CGD team. What I'm going to present is how we have used adaptive HTA over the last 1 year, and informing the clinical guidelines which are being developed by National Cancer Grid. So most of you are aware what National Cancer Grid is, but just to give a brief introduction, National Cancer Grid is a initiative from Department of Atomic Energy being coordinated through Tata Memorial Center. It's a network of cancer centers, research organization, and patient groups. And as of today, we stand 250 plus members who are part of National Cancer Grid. The mandate with which National Cancer Grid was started is to ensure that there are uniform standards of cancer care across the country, develop, train human resources to deliver this optimal cancer care across the country, and to facilitate and promote multicentric collaborative research. The first step, which was a very obvious step since we are talking of uniform treatment of cancers across the country, was to develop guidelines. And these guidelines have to be based on evidence, evidence-based medicine, which can be translated into the clinical practice. And the purpose was to ensure that a basic minimum level of care is given across our own country, as well as this can be applied to other low middle income countries. There were several guidelines which are available, so we wanted this to be different, to have representation across different regions, to address all cancer sites and have it in algorithmic format, starting from the clinical presentation so that anyone can refer to these guidelines very easily, and having it in algorithmic format, not in a full document, running in terms of pages. These guidelines lend themselves for easy review as well as revision as the new data comes. And therefore, since there are 250 plus members. One can see that the guideline have a potential for huge impact. However, we realize that the availability of expertise and infrastructure across the country is not same. It is a very wide spectrum. Revised to develop resource stratified guidelines. And so these are the three stratification which we worked upon. The first one, what we call as essential, is basically the guidelines or the interventions or the diagnostic methods which are based on evidence, practicality in terms of the expertise and the infrastructure, along with the cost and the value of the intervention or the diagnostic method which is being offered. And if this is the basic minimum level of care, and if a center cannot deliver or do not have the capabilities to implement either in terms of infrastructure or expertise, then this needed a referral of patient to the next level of care. The next set of guidelines we said are optimal, and these are the recommendations which were based both on evidence available as well as cost effectiveness data. But at the same time, this optimal category was different from essential category, that it was limited by the issues of expertise and infrastructure, and therefore this was the basic differentiating feature between the optimal and essential category. The third category was optional, which was basically to include state-of-art interventions or diagnostic methods purely based on the available evidence with no consideration for cost effectiveness. So these were the three categories. Another important thing which happened with these revisions, that these NCG guidelines were linked with the PMJ, and the optimal category was selected to facilitate the authorization and the claims for the PMJ HBB packages. And with that came the responsibility that since the optimal category is linked with the PMJ health benefit packages, it is important that we need to have evidence of cost effectiveness, not just based on the experts' opinion, but with the hard data of the HTA, so as to make sure that these decisions are transparent and evidence-based. So once an intervention or diagnostic method is included in optimal category, there is enough evidence to say that it is cost effective, and which is an objective evidence. However, we know that, as Casey mentioned, doing a full health technology assessment for all these interventions which are part of NCG guidelines would take us a lifetime before we are able to complete, and by the time new interventions will come up as the evidence is evolving. Therefore, we needed some bit of pragmatism, and that's where we came in contact with the Center for Global Development, and we started doing adaptive HTA for the interventions which we identified as high priority. So over last 1 year, we have completed 6 fully. There are 4 of them which are in pipeline. And with each of these adaptive HTA, we have developed the methodology more, and the methodology has evolved. And it has been done for a variety of interventions, not only just the drugs or the targeted therapy, but even the surgical and radiation interventions also have been included in these adaptive HTA. With the long-term goal being that we want to institutionalize these adaptive HTA to inform guideline development on the regular basis, and therefore can inform the health benefit packages more objectively. So this is the process which is followed for adaptive HTA till date, what we have conducted. So first is the selection of which intervention we want to look at. So the priority interventions or the priority oncology drugs, this is based on the disease burden, the extent of use, as well as the cost. So that's the that has been the basis for selecting the interventions or the drugs, or whether we talk about a surgical intervention or radiation technique. After the intervention is selected, the next step is scoping, and then based on that scope, the available data is assessed using a particular template, which I'm going to display in the next slide. looking at the safety, effectiveness, and the cost effectiveness. And this is not just from the our own country, but international whatever international data is available in these fields. And if in case the data is not available from India, then this entire information is contextualized with respect to our own country. The next step comes is the price analysis, where we determine the price which is being paid for that particular drug or intervention in comparison to the other countries. The subsequent step calculates the cost. So suppose if this particular drug or intervention is included in the health benefit package, what would be the cost per year? And this cost takes into account what proportion of innovators are being used, what proportion of generic is being used for the defined package which we are talking about, and what are their related pricing mechanism. And herein, even the expert review is taken that what are the Indian practices in terms of prescription and in terms of the appropriateness of this package. So this provides a budgetary estimate. And the last part is that there are some points which we may not have covered in all these three steps. So there is a feedback assessment taken to understand that the evidence or the value for money judgment which has been derived is how much what is its appropriateness with respect to the Indian context, and if there are any concerns which have not been addressed in this entire process of adaptive HTA. So just to give you an example, just to maintain the confidentiality, I'm not going to say what drug and what exact intervention, but since once the NCG guidelines are there, they are available for public use, and we do get requests from these different stakeholders to include an intervention into those NCG guidelines. So we did receive a request from a pharmaceutical company for inclusion of the drug in the guideline and therefore in the package. To recommend an inclusion, we needed an objective evaluation of the drug/intervention to understand what are the financial implications if we include this drug into the NCG guideline and then, obviously in the health benefit package. And therefore, we planned to do an adaptive HTA to assess the cost effectiveness for this particular drug and the budget estimates. So as I had mentioned earlier, that the first step which is adopted is to develop a scope for the intervention, and this utilizes the PICOS framework. And this is something which is done in all health and economics research. I'm no expert by any means on this health economics research, but this is what is used just to provide the comparability, because we are comparing across different countries. So we just need to make sure that our decision problems are similar. The studies have addressed the same decision problems, and the evidence is available for the same decision problem across the, different countries, so as to have the comparability of data. So typical framework has population, and for this setup, we, let's presume that it is, we are talking about metastatic breast cancer, which are untreated for first-line therapy who are hormone receptor positive. And this is our new intervention. Comparator is taken as the standard of care listed in the NCG guidelines. The outcomes which are evaluated include safety profile, clinical effectiveness, cost consideration, cost effectiveness, as well as uncertainty in terms of data, in terms of decision making, as well as the methodology which has been utilized in different studies which are evaluated while data extraction is being done. We define if there are any particular subgroups of interest which will be important while we are making our policy brief. We look at the cost in our own country and a justification. So as I said that, when we select an intervention for adaptive HTA, we want it to be meaningful and, where the impact is going to be largest. So therefore, for this particular situation, the justification was that breast cancer, we have high prevalence, almost 10 to 20% are metastatic at the time of diagnosis, or they evolve into, having a metastatic disease later in the course. And there is need for improving outcomes in this subset of patients, and this particular drug in consideration, there is increasing use in the country, and therefore we needed to develop a formal evidence with the help of adaptive HTA. So this is the template which we use for all these adaptive HTA. It has data from different countries, safety data, which includes adverse events, any particular groups where restriction is needed, whether there is marketing authorization by the provided by the regulator in that country, what is the dose, clinical effectiveness in terms of overall survival, progression-free survival, quality of life, and the cost effectiveness data, which includes ICER, price, the discounts which are being offered in different countries, what are the resources which need to be utilized if we recommend this intervention, and the uncertainties with the available cost effectiveness data. So this is again a dummy example for the same intervention which we were trying to address. So this is the pricing analysis, and here we look at the price benchmark. So we look at the drug price in the India. We look at the purchasing power parity for India, and we look at the benchmark price in the other country. And this is typically which is taken from the open source data, whatever is available. So we may not know actual prices which are being offered in these countries, but whatever is available open source is what is taken as benchmark price. Then we look at the benchmark country's GDP, and then the India's GDP and this benchmark country's GDP allows us to develop this adjustment factor. We convert the price which is there in India into the currency of the benchmark country, and using this adjustment factor, we calculate the pro rata price. And this gives an idea that what is the cost which we are paying, because typically the notion is that the cost of the drug, if you look at actual price, it appears that it is lower than what is there in the benchmark country. But when we do this adjustment based on the purchasing power parity between the two countries and we generate this pro rata price, it tells us how much more we are paying at present for the same drug in our country. How it helps? One, it allows us to understand the budget impact. The second most important thing is that it gives us the capability to understand what prices we should be negotiating if this particular drug has to come into the guideline or in terms of health benefit package. So for this particular drug, as you can clearly see, that the Indian price, if you look at, and if we look UK as the benchmark country, the price appears much lower as compared to the listed price in the in United Kingdom. But when you convert this into pro rata price, you realize that we are still paying close to 3.5 times more than what the price is being paid in UK. And just to emphasize on the fact that this price is the listed price, we do not know what discounts are being offered, because those are not available freely for understanding as well as calculation. So this is what adaptive HTA helps us. And then after we get that what is the benefit, whether we should be considering this particular drug into inclusion, if this drug is considered in inclusion, what will be the budget estimate given the number of patients, the number of cycles which will be needed, what will be the wastage, as well as how long the therapy would be continued. So based on that, a costing analysis is done. And for this drug, we realize that we know that PMJ offers for per family the reimbursement is around 5 lakh. That's a threshold. And if we looked at this drug, it was coming just below that particular threshold for entire family. So it may look that it is feasible, but looking at the entire cost analysis, the budget impact appears huge, because for the same amount of money, we will be cutting down several other life-saving interventions if we bring in these kind of drugs into the optimal guidelines or into the PMJ package. So as I said, that the last bit which is done in this adaptive HTA process is to collect the feedback from the clinicians who are part of the group, just to ensure that anything which has not been covered in the entire HTA process, all those areas of consensus or dissent can be identified and listed when we are preparing our policy brief. And this is what, the output of entire HTA comes out as a policy brief, which summarizes the review of literature, the recommendations from other agencies across different countries, the price analysis, summation of treatment costs, and other consideration. The plan is that all these policy briefs can be made publicly available, as well as help the guideline development group to develop and inform the guideline development process. So this is our intent, is that all this adaptive HTA will feed into the NCG guidelines, and so as to ensure that whatever is being listed as an optimal category is cost effective based on the adaptive HTA evidence. This is all from my side. If there anything which is not clear, I'll be happy to take the questions.
Thank you so much, Dr. Manju, for that fantastic and clear presentation. And I'm sure many of our participants would have really been delighted to see some of the work being done by the National Cancer Grid, especially on sort of the pricing and how it impacts health benefits packages as well, and adaptive HTA and how that impacts health benefits packages. I can't see any questions in the chat box. And so if we are okay, then we can move on to the panel discussion for everyone. And so for today's panel discussion, we have Dr. Shankar Prinjar, Dr. C.S. Pramesh, and Dr. Ganesan Karthikeyan joining us today. Welcome to all three distinguished panelists today. And so I guess I'll begin with you, Dr. Pramesh. You've been working with CGD and the NHA for quite a while on adaptive HTA health benefits packages, STGs. What do you think is sort of the magnitude of impact that adaptive HTA can have, not only for standard treatment guidelines, but for benefits packages, procurement, and then healthcare, healthcare at the end of the day in India?
Thanks, Cyril, and thank you for including me in this panel. I think it's been wonderful listening to Cassie and Manju about adaptive HTA and how it works, and I think they did a brilliant job in looking at the pros and cons of this approach. For us at the National Cancer Grid, the issue was very clear, and we had a fairly easy decision to make as to whether to go ahead with the adaptive HTA, primarily for the reason which Manju alluded to in her talk, which was that we don't have the luxury of waiting for ages to set up a robust traditional way of doing HTA. And we needed to come up with something quick and dirty which would answer our questions and feed into our resource stratified guidelines. To me, that's the single most important benefit of taking this approach, because as all of us know, it takes anywhere from 18 months to 2 years to finish one HTA for one intervention that's being done. And considering the thousands of interventions that we have, not just in cancer, but in other healthcare areas, I think we would be years or decades away from establishing a setup which would be capable of doing that. And just to give you context, the kind of resources it takes, and plenty of people here who worked with NICE before, but NICE employs hundreds of people working entirely on this, on HTA, probably thousands of others who are brought in as experts and advisors, each of them working anywhere from a year to 2 years to complete one full HTA. So the very challenges that we face here of coming up with something that we consider as a perfect solution will actually end up being the hurdles in coming up with a more practical, feasible option which is readily available. And that is the reason we took up this approach of adaptive HTA. And for most interventions, the answers are very clear. So for some of the interventions which Manju mentioned, out of the 6 which we've completed, some drugs or interventions needed to be brought down in cost by 1/4 to 1/4 of what the actual cost is for it to be cost effective. So these are easy decisions that you can make in adaptive. I don't think you really need a full HTA to come to a conclusion like this. It's only when you have these gray areas, the ones that are borderline, that you probably need to get into a full HTA. And in addition to being actually feeding into our guidelines, I think this is a terrific way of triaging which interventions that you want to get into a full HTA. So I see a lot of benefits, fully understanding the limitations of an adaptive HTA.
Thank you, Dr. Pramesh. So I'd like to bring in Dr. Shankar over here, actually. So, Dr. Shankar, you've obviously been doing a lot of sort of traditional HTAs, and you're also working on validating adaptive HTAs. Given what Dr. Pramesh has said, where do you see adaptive HTA working? How can the NHA potentially adopt adaptive HTA? How does it link to HTA in? All of these are sort of questions that I'm sure you'll be able to provide us with some perspective on.
Yeah, thanks, Cyril. I think that the points that previous speakers, Cassie and Dr. Manju mentioned, and which was also highlighted by Dr. Pramesh, the sort of divide between the extent of demands that we have on evidence needs and the supply of people who could possibly do that in a more of a kind of a real-time basis in which the decisions are to be taken. There's a gross mismatch between these two. So definitely, given that background, we definitely have a scope for adaptive HTA. So that's a kind of a settled question. So it's not to say that. And 2 points that emerged very clearly from what Dr. Pramesh also mentioned is that one, that the potential application of adaptive HTA is definitely in topic selection. So from the perspective of HTIN, I think topic selection is one area where adaptive HTA could definitely play a role, which means that they keep getting a lot of topics. In a lot of those topics that are received, not all of those topics get commissioned for a full HTA. And the reasons are related to perhaps the extent of importance that is accorded to a given topic based on the burden of disease, based on the extent of public money decision that it involves, based on the effectiveness of interventions that are available, etc. So there are defined criteria based on which HTIN makes those decisions. I think one definite area that could be added within that is the adaptive HTA, so that resources perhaps could be freed for the full HTA on those topics where there is a blurry kind of evidence with regards to adaptive HTA. The second area that I see that has a very clear application, and that is an area where which could be of great importance to not just the NHA but also a lot of state drug procurement agencies, is around price regulation or price setting for that matter, or even a regulatory agency like NPPA. So the information that is generated through price benchmarking that was demonstrated by Dr. Manju in our illustration is a very classic example that could be used and applied in order to make decisions around price benchmark, price regulation and procurement decisions. So those are, I think, very clear takeaways and examples where we could use them both for HTIN and for NHA and similar other procurement agencies. The caution would be for topics that involve, let's say, things related to health programs, or where the price is not just linked to a given program. The programmatic interventions are more complex interventions, and these complex interventions require not just a price of a given drug or a device, but it involves the entire cost of the entire the way that you implement the program. And this could have very significant differences across different country contexts. So the generalizability of the evidence in this particular area would definitely be a question. So perhaps there could be a role that the full HTA plays much more in the context of programmatic evaluations, for which are to be used based on HTA decisions. So I think that's an area. And definitely, I mean, what you mentioned about the validation. So in partnership with the CGD, we're trying to develop a methodology which could be used to validate the evidence that comes in from the full HTA, from a pragmatic HTA, and we compare that against a full HTA. So that would help also instill certain confidence among the users in order to rely on the evidence that is generated through adaptive HTA. So maybe I'll stop at this, and maybe we can take up more questions later.
Thanks for that, Dr. Shankar. So I'd like to bring in Dr. Karthik over here. Dr. Karthik, we've had a few discussions earlier on sort of adaptive HTA, and you've obviously seen the work being done in oncology. How can you see adaptive HTA being applied to cardiology as a field, but also sort of benefits packages for cardiology? Do you think there would be appetite within the community? And what sort of impact could you envisage with regards to adaptive HTA?
Thanks, Harold. Are you able to hear me? This internet is kind of dodgy, so I'm just going to.
Yes, we can hear you.
You're not able to hear me. Okay. Thanks again for having me on this panel. It was good to see those nice presentations from Cassie and Manju. I'm going to repeat most of what Dr. Pramesh and Shankar said. So first of all, I think in this context, in the context of adaptive HTA, better is probably not as, better is probably not what we should be shooting for. Good is good enough. So adaptive HTA is probably quite suited for cardiology, especially because the way I see it, the evidence base for most of the interventions that are in regular clinical practice is already there. So you really don't have to spend time reinventing the wheel on those. So you don't really have to do a systematic review for effectiveness. So the only place where we need to look at things on the cardiology side is the cost side of things, because everybody is aware the wages are different and the costs are different. And like Dr. Manju showed very clearly, in fact, there is no reduction in cost as far as high cost interventions in cardiology are concerned. They are just translated straight away. So you pay exactly the same dollar price for a stent in India when compared to the US, for example. So that makes it more necessary for us to just work on the cost side of things and show whether the same interventions which were shown to be cost effective elsewhere are cost effective here. So and as far as the appetite goes, I think the moment you talk about reimbursement from a government scheme, which is in this case the PMJ, it is probably the best way of implementing such a scheme. So the amount that needs to be reimbursed from doing a simple adaptive HTA economic evaluation, where we can show that this is the price at which it becomes worth the government's money to do a particular intervention. So I think this is important, like Dr. Shankar said, in terms of cost setting for expensive interventions. And there are some interventions which are clearly cost effective from a pure ICER metric, which probably doesn't apply to us at all, because the HTA, and the one good thing about it is, I think Shankar just briefly touched on it. We talk more about the budget impact, and it's not just the ratio of the pro rata cost like Manju showed. It's also important to consider it from in absolute terms, in the perspective of what our per capita GDP is. So that's one more absolute way of looking at it. So that has a clear budget impact in terms of how much money is available for a particular in the health budget of a state or a district, or even the country for that matter. So it's important to consider these two things. And I think we have already done with the help of HTI and several the low-hanging fruit kind of economic evaluation for very frequently used interventions like angioplasties and bypass surgery and pacemakers and devices. So I think there is appetite. As long as the PMJ wants to pay for it, then we have to, I think, before they can decide how much to pay for it, we need to do a simple economic evaluation to find out what is the set the benchmark cost. I think that's more or less what I want to say. If there's anything else, we can discuss more specifics. Thanks.
Of course. Thank you so much, Dr. Karthik. So we've actually got a few questions coming through on the chat box, and one of the questions is linked to, how do you do an adaptive HTA should you be doing an adaptive HTA if there's not enough studies available internationally to validate any sort of work that you're doing in an adaptive HTA? So it's more of a question of when do you use adaptive HTA versus when do you use full HTA? And maybe Dr. Shankar, you could provide some perspective, and then we can defer to Dr. Pramesh as well on some of the work that he's been doing in the National Cancer Grid too on this.
Yeah, sure. So I think that couple of important prerequisites for an adaptive HTA would definitely be that you need to have some existing evidence that has evaluated those drugs. Definitely, without an existing evidence, there's hardly anything that you could comment on, or in fact, absence of existing evidence would be one of the pointers towards carrying out a full HTA in your setting. The second sort of consideration that you may also bear in mind is also that how much do you consider the generalizability of the evidence from one setting to the other setting. So maybe you could have some kind of decision rules to say that a study having been done in a given setting is likely to be generalizable in our context as well. So that's the second thing. So if you feel that there are major differences in terms of healthcare delivery structures or other ways in which the intervention is delivered, then perhaps you would be less confident in using that. So that's one thing. The second question is that any of the may do highlighting on the exponential rise of demand healthcare services and cases adaptive HTA proved useful in context. So I think that's a very specific question on COVID that has adaptive HTA been of some use in the COVID context given the. So I mean, I definitely can say for sure that yes, given the excessive demand on evidence that comes with a kind of a situation like COVID, this definitely places more of a role for more pragmatic approaches towards evidence synthesis, and adaptive HTA offers one of those. But then the question again is that for those set of things that are being questioned in the context of COVID, do we have the existing evidence? So that's definitely going to be a question. Over to you, Hiru.
Thanks for that, Dr. Shankar. And just to point out that, so adaptive HTA has been used for COVID, actually, even in the Filipino HTA agency created a adaptive HTA process, an expedited process to basically undertake evaluation of COVID sort of technologies to try and turn around evidence as quickly as possible into policy. My question is more to Dr. Pramesh now on, there's so many novel cancer drugs coming out. There's obviously loads of industry-sponsored trials and all sorts of things going on in sort of the cancer world. How do you sort of then decide what you would potentially send to HTA in for a full HTA and what's an adaptive HTA for NCG guidelines?
Thanks, Cyril. That's a great question. But before I address this, let me just very briefly address the previous question that was asked on the chat, which is about if you don't have the evidence, what would you do? So in an ideal world, adaptive HTA would rely on previous HTAs, full HTAs having been done in a bunch of countries. But I will take this one step further and suggest that, yes, if we do have full HTAs done in other countries, that's the ideal situation. But even if you don't, and COVID is a great example for this. So if I had to go outside the world of cancer treatment for an adaptive HTA, I would love to do one on the antibody cocktail that's been suggested now for COVID, because I have no doubts that it will not be cost effective when it comes to treatment. Because one, it's used for mild disease where 95% of patients get better on their own without any intervention. And in the marginal area that it benefits, mortality is reduced, remarkably low. So if all it would do is just put in a lot of numbers into it, you don't need fancy data on exactly how much it took to administer the cocktail, antibody cocktail. You just bring in estimates of what the antibody cocktail for COVID would actually cost, put in the number needed to treat and how many lives it saves, and I think you'll have a quick answer to that. So these are extremes. I do understand that in those areas where there are not extremes, when the costs are in between, you probably would rely on studies done in other countries. So coming back to your question about cancer drugs that are coming up and how we would approach them, I think it's incumbent on us before we recommend drugs that it goes through some kind of a however quick and dirty it might be, some kind of a cost effectiveness study. I do understand that cost effectiveness is used very loosely here, and it runs the entire spectrum from just finding out what's the cost of a drug in a country and whether it's worthwhile using it to a complete full HTA analysis by itself. But what we are seeing more and more in oncology especially is marginal benefits of new drugs coming at an extremely high cost and actually not impacting on the outcomes. There are terrific studies done by Tito Foyo, Katarian, many others in this field who've shown that the exponential increase that we've had with cancer treatment have very little impact on actual outcomes, whether it be overall survival or quality of life. And I'm a firm believer in the fact that we need to look at two important outcomes, at least in cancer. How long do you live and how well do you live? And these are reflected in these two parameters, which are overall survival and quality of life. And any drug which does not impact on these and comes at a huge cost are something which we should probably be extremely selective about championing and not allow the cheerleaders of these kind of interventions to dictate the path that these interventions go.
Thanks, Dr. Pramesh. Dr. Karthik, any reflections from you?
Yeah. So I agree with what Shankar and Dr. Pramesh have said. The one thing I would want to add to it is that in the context of COVID, that's a classic example as of now. I think the first, so if we were to follow an algorithmic approach to choosing which areas to choose and which particular conditions to choose for doing an adaptive HTA, I think the first requirement is that they need to be shown to be effective. So if you go by that metric for COVID, it's almost everything goes out of the window first. So you have very inexpensive, say something like dexamethasone, which is cheap and it reduces mortality, but nothing else even comes close. So I think if we have a metric which prioritizes survival benefit, then that would be the first step in the algorithm. So having said that, I also want to add that survival benefit in itself is not a homogeneous metric. Like Dr. Pramesh pointed out, how long do you, so what is the survival gain? For example, in cancer therapies, in advanced cancer therapies, the survival gain is say 3 months, but it still is presented as a survival benefit. So we need to be conscious of that as well. And I guess we have to make value judgments in deciding which ones to choose over the other. So there is an element of value judgment involved here before we decide, okay, this is what we prioritize for an adaptive HTA and this one we don't. So that was one point that I wanted to make.
Fantastic. So I can see a hand is up. I think, is it Sunil? Is it yours?
Yes, Dr. Sunil this side. I have a very basic question based on the a very well-informed presentation which has been shared right now. So we can assume that in Indian context and especially in our scheme Pradhan Mantri Jan Arogya Yojana, so there are a lot of health benefit packages and which their treatments require provisioning of drugs. So as we can understand from conducting an adaptive HTA, we'll get to know which drug is more cost effective, and as also mentioned by Dr. Pramesh and Dr. Karthik, that we also have to look at what benefits are we getting through that intervention. So the question is in Indian context and considering the factors involved in Indian context, like larger population and various diseases, the disease burden and all, what is the suitable approach of conducting HTA, the traditional HTA or the adaptive HTA?
So I guess this is a question which goes back to sort of topic selection and sort of the idea of, how should, especially for the NHA, how should they go about doing adaptive HTA versus sort of full HTA. Maybe Dr. Shankar, you'd like to come in over here, provide some reflections?
Yeah, I mean, I'll again try and re-articulate the same thing that I tried mentioning earlier as well, that given the large demands on topics that the NHA would need to get evaluated, considering that there are more than 1,500 plus health benefit packages, and within a given health benefit packages, there are different standard treatment guidelines. So there could be quite a large number of questions. So this is kind of an ideal setting where adaptive HTA has a very significant role to play, given the fact that, as Dr. Pramesh was mentioning, it's going to take ages to get the evidence for all kinds of questions that the NHA might have. So what it means is that there could be some that could be fairly easily addressable through a targeted review that is done as part of a pragmatic HTA, where you basically review the existing guidelines for HTA that have been approved in other country settings. And given the fact that you feel that they are likely to be similar in your context as well, you can take decisions based on that. There could be others where there could be questions on what should be the appropriate price that you should be setting for reimbursement in the context of treatment for a given drug. Again, the kind of example or illustration that Dr. Manju showed about price benchmarking is something that could be done. And then for the rest, where you feel that there is a kind of a you need more work to be done, then a full HTA could be there. I feel that there, in terms of the logistics of it, that how does it get the operations of carrying out all of this activity? I think that a good coordination between the NHA and the HTIN would definitely be a good stepping stone towards setting up of a system where a large section of the topics could be addressed through adaptive HTA, but then there are a few that could be referred for a full HTA. So there needs to be a very constant liaising and linkage between the NHA and the HTI. I think that's the way forward.
Thank you for that, Dr. Shankar. Dr. Pramesh?
Thanks, Cyril. I just wanted to use this opportunity to both pose a question to the NHA as well as a suggestion, considering that we have some of the leaders of the NHA on this call. The first would be to actually learn from NHA, and maybe Dr. Sudha can pitch in on this, as to what they see as the place that adaptive HTA has in this entire process of trying to figure out what is value for money. And the second is that while we have a bunch of people on this call, considering that we are a country as large as India, which doesn't have an HTA process in place, we probably need to multiply the number of people who are even remotely interested in health economics and HTA 100-fold. And I'm being very conservative here. Is this an opportunity and a serious proposition to the NHA to look at championing the cause of health economics and HTA in this country? We do realize that there is a need for huge capacity building. The number of people that we currently have interested need to be multiplied, as I mentioned, at least 100-fold to be able to do this. And is there a way that we can in some way support this by way of funding, by way of any other kind of support that they might need?
Thank you for that. Dr. Sudha, go for it. Yeah.
Basically, I think we have been identifying the areas as and when it is coming. So what we are trying to do is, apart from the kind of processes, the packages that we have already developed with the essential list. So whenever there is new evidence, there is new feedback from our clinicians, hospitals, states, we are trying to compile them and capture them so that we are sorting it at our level itself and then pushing it for the next level, whether it is, if it is cancer specialty, then we push it to the TMH and the NCG team to relook and send us back. So that, I think, one of the examples that we have also done is to also say no to a lot of pressures that we get, you know, because the hospitals, the clinicians, in any forum they keep telling that this procedure is not available, this package, this drug is not available. So there are a lot of pressures for finalizing the packages also, and to introduce, as we said. So one of the ways we use the HTA and try to get a rapid adaptive HTA done is to ensure that we are very confident in responding to all these pressures in a very evidence-based, transparent way. It is not that it is not our interest to include or not include, it's not an individual or a small team decision, but there is enough evidence to say no, or, and then we also push for inclusions whenever there is a need. So those are things that we need to do. It's a continuous process. I don't say that, it happens today and it doesn't happen later. So it is a continuous process at the NHA level that we need to keep doing it. And in terms of the strength and the capacity to conduct these HTAs, I think we closely have an MOU with the DHR and the HTA in. So we have been pushing some full HTA studies to them also. So as and when we get requests for newer technologies, newer methods, newer approaches to compared to a conventional processes, we are trying to push it to the states to do it. We are trying to be the kind of seed, so that so many things, feedback we are able to collect, but we are trying to see where it should go, the best place it can go, so that it gets answered, and then we follow it up to get the feedback and then incorporate it back into our scheme. So it's it has to be done in a very clinical precision way to ensure that we have a transparent process for that. So that is how we are doing now, and pushing it back to the states, and then the technical capacity of the states is being built. At least some efforts constantly are being done through the DHR to build our technical partners in most of the states and institutions. So I think it's a very consolidated, integrated effort. So as Pramesh says that, we need to do this, but it can't be done by any one wing or even ministry or at the state level. So it has to be a concerted effort to build the capacity and involve the academic institutions at the state level and ensure that there is good feedback. So I think that's the way forward, and we have made a beginning. I think it's good to keep it going.
Thank you so much. So I know we have about 4 minutes left for this discussion and panel discussion. And so I'd like to invite each of the different panelists and Dr. Sudha as well to just provide a short sort of final perspective on ways forward for the NHA, for sort of academic institutions, for your own respective fields with regards to adaptive HTA, healthcare priority setting, health benefits packages, and the whole diaspora of these things. So we'll start with Dr. Karthik.
I'm going to keep my video off. I think I lost you the last time I was speaking. Are you able to hear me now?
Yes, we can hear you, yes.
Okay. All right. Sorry. Yeah, the way forward is interesting because I think, from going from a purely economics perspective, if you leave the choice of HTAs, the topics, to clinicians, then they're going to be overwhelmed very, very quickly. So I think the best way to go about it is to go about it from a payer perspective. As of now, the NHA or the PMJ, if you look at it from their perspective, just look at the drain on resources, prioritize the ones which are consuming the most amount of money, and do HTAs on those. The next step would be to go one step further and look at actual disease burden in cardiology, which are the things which are really causing most of the loss of life or loss of quality of life, and then address those. That would be the next step. The first step, I think, would be to just go by what is consuming the most resources from the NHA/PMJ. I think that is my suggestion.
Thank you, Dr. Karthik. Dr. Pramesh?
Thanks, Cyril. So I'll just very briefly summarize what we've already spoken about. The fact that most of our interventions ideally require a HTA analysis, full, adaptive, rapid, whatever you might call it, but we don't have the capability to do it right away. So I'm a big champion of adaptive HTA as a mechanism of weeding out the clear goes and the clear no-goes. And I think that's a huge area that we could work on, wherein a fairly large proportion of the interventions that we currently do could be categorized into the clear goes, no goes, and the in-betweens. The second thing, again, repeating what I earlier mentioned, is that some organization, and I'm allowed to hear Shankar's views on this, the current mechanism that we have for HTA between the DHR and the HTAIN is woefully inadequate to address the huge number of interventions that we currently have in front of us to do a proper HTA or even a rapid or adaptive HTA. And I'd love for some organization, some healthcare organization in the country to take up the gauntlet and work towards building capacity. Within the cancer space, we are happy to do that as part of the National Cancer Grid, but I do realize that cancer is probably, 8-9% of the overall disease burden in India. There's 91-92% of other diseases that we need to deal with. And I wish that some healthcare organization would take up the responsibility of creating capacity in these organizations and look beyond DHR and HTAIN. I think they are a great organization. They could be the mentors, they could be the trainers, but we need a multiple such smaller places, a kind of a hub and spoke model where we are able to work on this. And I think this is ideally done disease specific, as we have shown with the cancer model.
Thanks, Dr. Pramesh. So Dr. Shankar, over to you.
Thanks, Cyril. I think it's been very enjoyable listening to all the views. I'll begin with on a lighter note that I think that given what Dr. Sudha mentioned, I think the NHA should use the tool of HTA and the agency conducting HTA studies as a punching bag for their decisions. So all blames goes to the HTA agency and all the good things the NHA takes on. Okay, so that's on the lighter side. But I think that as a way forward, I do feel that there definitely, over the series of these 3 or 4 webinars that we've had, I think there's been a lot of interest and there has been a lot of demonstration of applications that economic evidence could help to bring in better decisions. I think that's been a very hallmark of these discussions that we've been having. So in the same line, I think that what we said earlier as well, that there has to be definitely a linkage between the decisions that are being undertaken in NHA with the kind of evidence that the HTA could generate, which means that there has to be certainly a linkage between the NHA and the HTIN, but also understanding that the needs of NHA are going to be almost like infinite. So the DHR would also have to be very responsive to the needs, to the evidence needs of policy making, because the decisions would in any case be taken with or without the evidence. And in that light, I think that the role of pragmatic approaches towards generating evidence increase multifold, because either you keep waiting for the best possible evidence to come up or take the best decisions given the available evidence that you have. So definitely that highlights the scope of the application that adaptive HT can happen. Coming to the point about capacity building, I think that there has been an attempt, and as Dr. Pramesh mentioned, that the needs are immense. So the need to build capacity is way beyond what we can actually foresee. There has been some attempt in that direction, and there has been a lot of, so it's not just the DHR. So there is a kind of a hub and spoke model within what the HTIN is also trying to do. So there are currently about more than 20 regional resource centers or institutions that have been identified. And there are about more than 20, again, technical partners that they've also identified. But I do agree that all of these resource hubs and technical partners may not be at that level of capacity to be able to independently conduct the HTA studies. So I think these are some initial few beginnings that are being made. And over the years, we'll probably see a little better capacity in terms of handling the evidence needs. Thank you.
Thank you so much, Dr. Shankar. And Dr. Sudha, maybe a final word from you before we conclude this discussion would be very nice, I think.
I think a lot of good suggestions has come in from the team in terms of what is needed. And we are aware that HTA is still a new concept within the decision making. So definitely the kind of shift that it needs to absorb the evidence and use it has to be, strengthened even among the policymakers. So that is also important, that, even when you do a good HTA and take it to the policymaker, whether they will accept it or not, and do they have the capacity to absorb the complexities of the kind of inputs that you're providing. So I think that is also one channel I think we had initiated. The policymakers also need to be sensitized in terms of these. So it is not only bringing in the academicians and bringing the capacity, but give a good balance and ensure that that is done. Definitely, I think NHA has because being a very good, large strategic purchaser of services, can use that leverage and ensure that, as we go ahead, that certain kind of decisions are based only on evidence, and ensure that, the inclusions or exclusions happens not just with the expert consensus and the kind of revisions that we are doing, but are very deeply rooted, like many other developed countries, wherein nothing gets into the National Health Service without having a good justification and evidence base. So I think that's the level we want to see, within our own country also, that the use of HTA happens. But it will take some time, and I think these discussions, these things need to be, percolate down and happen even at the state level. I'm very believer that, India or national level cannot bring this change. It has to percolate to the states. Even states has to take this initiative very closely and do that, and then they can, then it becomes a moment. Then the momentum improves. So definitely, that's, I think, what is the vision for HTAs, to make sure we go down and deeper.
Fantastic. Thank you so much for those final words, Dr. Sudha. And very big thank you to all of our panelists. Dr. Pramesh, I think you have a final word to say.
Hiral, thank you. You've done a brilliant job moderating this session, but I'd like to hear a couple of final words from Cassie and Manju as well, considering the effort they've put into this.
Yes, definitely. Cassie, Manju?
Cassie, you go ahead.
Thank you so much. Just to say a big thank you. I think this has been a really interesting session, and I'm really pleased to see that there's so much interest in adaptive HTA and really just this concept. One thing I think it was Dr. Shankar said, and I wrote it down, better is not what we should be shooting for, but good is good enough. And I think that's really motivation for us to keep developing the methods. I think there's a lot of work that still needs to be done on adaptive HTA and figuring out where we can best use it, but it seems like I'm really excited about the prospect of adaptive HTA, and especially this idea of the hub and spoke model, where we might be able to pool together people in different disease areas in order to work on developing adaptive HTAs in different pockets of India, and just the scale of it's very exciting to me. So it's an honor to have been here, and thanks so much.
Dr. Manju, go for it.
Thank you, everyone. So nothing much to add. What I just want to highlight from what we have learned over the year, many interventions which people, I mean the colleagues, feel that they are cost effective, and when we have put them through this test of adaptive HTA, we have realized that, they are not. And the impact it's going to have, if they are included in the optimal set of guidelines, are huge in terms of healthcare budget. So that's one thing which is an important learning. Many times we do get requests for the interventions which are not even effective, leave aside the cost effectiveness. So I think, that's something which we need to, before we take an intervention for an adaptive HTA, we need to ensure that, are they truly effective? Do they fulfill the parameter of magnitude of benefit needed to be even considered for a cost effectiveness analysis? I think that's one thing which we have learned. And as somebody had asked a question on whether there is enough data. So I guess first level is the effectiveness before we move on to the cost effectiveness. And at least for oncology, many of the interventions will fail at that level itself. And then we can, think in terms of cost effectiveness. So, so it's been a really a great experience over last 1 year. And I guess we need to do it quickly for several other interventions which are presently there in either optimal or optional set of guidelines, to make us, comfortable as well as confident when we recommend this as part of a national level guideline. So that's all from mine.
Brilliant. Thank you so much to all speakers, to all panelists, to Dr. Sudha as well for joining in as well, and to all audience members as well. And, you know, if you do want to reach out to us, to any of us, then please do shoot us an email. You can obviously find it easily on the internet, and Dr. Shankar has been in contact with you all very much before as well. And so back to you, Sunil, if you want to finish the session.
Thank you, sir. Thank you so much to all the speakers and the panelists for this enriching session. I'm already receiving texts on WhatsApp for this enriching well-informed session. I think this is happening for the first time that we are covering these kind of topics. And once again, thank you to all the speakers and thank you to the audience for the participation as well.
Brilliant. Thank you so much, everyone.
Thank you.
Thank you. Bye.
Bye.
Thank you.
Bye.
Thank you, Sunit.